commonly called as Whipple's procedure. This procedure is usually done for pancreatic malignancies and less commonly for traumatic injuries. So along with this, we are presenting the modification of the anastomosis in these two cases. One of these cases was brought to our hospital immediately after this trauma, and the second one, he came to us as delayed presentation after 10 days, after being operated somewhere else at private hospital. So this young guy, 17-year-old male student, he presented to us as case of RTI on 23rd of October at 11:15 a.m. It was two-wheeler versus truck, side impact, and the patient came to us within 1 hour. There were abrasions over the epigastrium and left ear and small laceration over the left ankle. Patient had pain abdomen and he didn't receive any pre-hospital treatment before coming to us. So on primary survey, airway was patent. He was maintaining saturation of 99% on room air, and he was in grade 2 to grade 3 shock, resuscitated with 1 liter of fluids, maintaining vitals, and GCS was 15/15. So in secondary survey, the additional findings were minimal abdominal distension, tenderness, and gourding. Gourding was equivocal. So I would call radio resident for the radiology images and description. We did PAN CT for this patient as part of our protocol, chest X-ray and pelvic X-ray. Dr. Nehia.
Good morning, respected all. I'm Dr. Neha from Department of Radiodiagnosis. So we subjected the patient to PAN CT scan, and here in the chest, we did a chest, pelvis, abdomen, head, and cervical spine for this patient. The head was absolutely normal in this patient. Coming to the images of the lung, we can see patchy areas of ground glass opacity in the posterior basal and lateral basal segment of the left lung. In the bone images, we can see there is a fracture, that is a cortical breach in the ribs 9th, and there was similar fracture in the rib 10th of this patient. We can see that there is hyperdense fluid collection in the pelvis. Upon measuring, the density of the fluid was about 57, signifying that it is a hemoperitoneum. We also saw that there were hypoenhancing areas which were wedge-shaped in the liver. It was grade 3 liver injury. We can also see a pocket of air, the intraperitoneal air here suggests that there was a pneumoperitoneum in this patient. In the lung images, we can clearly see this is a speck of air. Upon inspecting kidneys, we see a wedge-shaped hyper-enhancing areas in the kidney. It was grade 3 kidney injury. In the pancreas and duodenum, we can see that there is pancreatic laceration and the duodenal wall is hyper-enhancing and is edematous, signifying pancreatic and duodenal injuries. In the coronal reformatted images, again we can see the similar findings in the pancreatic head and the wall of duodenum. In the arterial phase images, we can see that there is discontinuity in the splenic vein and also contrast extravasation. This is the location. In the bone window images, we see that there is a fracture of the anterior column, posterior column, as well as the roof of the right acetabulum. We can see that there is a fracture of anterior superior iliac spine and left inferior pubic ramus. These are the 3D body render images. We can see that there is a fracture of acetabulum and also of the right anterior superior iliac spine.
Thank you, Dr. Neha. So our pre-operative diagnosis was grade 3 liver injury, grade 3 left kidney injury, pancreatic head laceration with intact, query intact main pancreatic duct, moderate hemoperitoneum with minimal pneumoperitoneum, left-sided 9/10 rib fractures with left pulmonary contusion, pelvic fractures as discussed, right acetabular fracture, then right anterior spheric and inferior iliac spine, and left side inferior pubic rami fracture, and open grade 1 left medial malleolus fracture. So there was a dilemma regarding the operation or not, whether we should go for operative intervention or non-operative intervention, this management. So the factors which were favoring the operative intervention were pneumoperitoneum in case of trauma. Though cases of pneumoperitoneum in chest trauma with extensive chest trauma without abdominal injuries have been reported. One of such cases has been managed in our department in last 1 month. And the factors which were favoring the non-operative management were grade 3 and liver and grade 3 kidney injury with moderate hemoperitoneum with hemodynamic stability. So grade 3 liver injuries, they are usually managed with conservative non-operative management. So we planned observation and then exploration the next day as the patient's vitals were stable and there was equivocal guarding. So we explored the patient next day. Coming to the intraoperative findings, we can see there is, on opening the abdomen, there is retroperitoneal hematoma around the duodenal region. Then on cauterization of the duodenum, on further exploration, we can see that there are multiple perforations in the duodenum and duodenal wall is contused. The main pancreatic duct is intact. So I think this might be the first case where there is complete pancreatico-duodenal disruption, but the pancreatic duct is intact. So we have not seen any case to best of our knowledge. So we can see here the pancreatic duct is intact, and this is the pancreas. Main pancreatic duct is intact, and duodenum has multiple contusions and perforations. So in this case also, we also see that the common bile duct is transected and skeletonized. So we proceeded further with pancreatic duodenectomy, with cholecystogegenostomy, with gastrogegenostomy, with Roux-en-Y jejunogegenostomy in this case. This is the this pancreatico-jejunectomy picture. Here is the pancreas. This is the loop of jejunum and the pancreatico-jejunal anastomosis. So the post-operative care was uneventful. Patient was extubated after 24 hours. Orals were started on day 6, and now patient is stable and planned for laparostomy wound grafting. This is the overall picture of the anastomosis. CBD was transected. There were multiple contusions and perforations of the duodenum, intact main pancreatic duct. So we did cholecystogegenostomy, gastrogegenostomy, pancreatico-jejunectomy, and jejunogegenostomy. So the challenges in this case were that patient had a right-sided acetabular fracture. So we had difficulty in early mobilization of this patient. So this is the present status of the laparostomy wound planned for grafting, and this is the present status of the patient on full orals. Patient is fine, doing well. So the other case, he was 6-year-old child who presented to us 10 days after injury. He was operated at some private hospital in Meerut. They, as per the documents received from the hospital, there was duodenal injury in this case, and they did the primary repair of the duodenal injury and laparostoma. And after 10 days, they referred the patient to AIIMS Rishikesh. So on examination, we can see that patient is on Bagota's bag with bowel hanging out of it. So these are the intraoperative pictures. There is total transection of the duodenum, and this is the Ryle's tube coming out of the transected duodenum, and this is the distal part of the duodenum. So again, pancreatico duodenectomy with the cholecystogeganostomy, with gastrojejanostomy, and jejunojejanostomy with feeding jejanostomy was done. This is the resected specimen, and this is a child doing well on follow-up. So coming to cholecystogeganostomy, the usual indications of cholecystogeganostomy, it is a procedure in which the anastomosis is made between the gallbladder and the jejunum. The usual indications are palliation for pancreatic malignancies, strictures of intrapancreatic portion of CBD, and dilated thick CBD which has lost its capacity to its elasticity. So one thing I would like to discuss here is that most of the patients who have gallbladder stone diseases or pancreatic malignancies, many of the cases their gallbladder is already removed. So in trauma, and the second thing is that in those cases gallbladder is pathological, most of the cases of gallstone diseases, whereas in trauma the gallbladder is normal. So there have been some reports of cholecystogeganostomy in trauma as well. So this is the overview of anastomosis of cholecystogeganostomy. Posterior layer first and then anterior layer. So I would like to take this opportunity to show you the cases which we have done in the last 3 years. We had total of 31 cases with pancreatico-duodenal injuries, in which one patient was cholecystopancreatico-duodenal trauma, isolated pancreas 23, isolated duodenal injuries in 3 patients, and pancreatico-duodenal injuries in 4 patients. 11 patients out of 31, they came to us within 24 hours, and 26 patients, they came after 26 hours. So coming to management, 18 patients were managed with distal pancreatectomy, 4 with Whipple's procedure, 2 with primary repair of the duodenal wall. There were small perforations on the lateral aspect. And 6 patients were managed conservatively, and 1 patient was managed with stenting. So 16 patients were having isolated pancreatico-duodenal injuries, and 15 patients has these injuries as part of polytrauma. The outcome mortality, we had around 22% mortality, and most of the cases most of these cases they were having polytrauma as associated as part of polytrauma. So the mortality as per the literature review, it's around 15 to 25 in case of pancreatico-duodenal injuries. So ours come around is 22.5% mortality. Thank you.